we're going to go ahead and get started since it's 10:30 and we have 2 groups to get through. My name is Dr. Janice Coffin. I will actually be the chair of primary care medicine at the Joplin campus. I did graduate here in 1998. I did a family medicine residency, served in the Army from 2001 to 2005, served in Iraq as an ER doctor, so carried an M16 and lived on the ground for the first year because we were the first ones over there. And then I've been at the Allopathic State School in Georgia and decided that I needed to give back to the osteopathic community that allowed me this profession. So it was wonderful to hear that you guys do grand rounds, because this is something when you get into your clerkships and residencies, every month in every specialty they do grand rounds, and you may be asked to participate in this. So being able to do this now and seeing how rigorous and how much time this takes is a great advantage for you guys when you get into your clerkships and residency programs. So please give respect to your colleagues who have spent this amount of time on this very difficult case of, this is group 5 presenting facial swelling in an 11-year-old girl. I believe that Lori Fitterling has sent out the IM chat, so if you want to go ahead and send in your questions or write the questions on the cards, and they will answer those questions at the end of their presentation. So please give them your full attention.
They're on? Hello? Can everyone hear me? No? It's on mute. How do I unmute it? All the top. Thank you. Okay, can everybody, there we go. Much better. Okay, good morning. Welcome to Grand Rounds for today. My name is student Dr. Rachel Olson, and I'm going to lead you through the first part of the case for group 5, which dealt with facial swelling in an 11-year-old girl. So I'd first like to acknowledge the student doctors of group 5 that put forth all the effort to bring this case to you today. And we will then move forward and start into patient history. So the chief complaint when our patient arrived at the clinic was that of painful, non-tender facial swelling on the right side of her face. The current illness, which was for an 11-year-old female, included ongoing fatigue over the past month, as well as recurrent night fevers, mild headaches, leg pain on the left tibia associated with a sports injury, and a dental issue approximately 3 weeks prior to coming to the clinic, which included incision and drainage of a presumed abscess. The dentist also prescribed antibiotics at the time, but no improvement in symptoms was noted. Patient's other past medical history includes only neonatal gastrointestinal intussusception. Patient is currently taking acetaminophen. However, that is for the leg pain associated with the hematoma on the tibia. Otherwise, no other recent changes in medications have been noted, and the patient also has no known drug allergies. As far as social and family history, the patient lives at home with the parents and the sibling and is physically active as noted with the soccer playing. The family's history is unremarkable for cancer, but there was a recent respiratory infection that the brother suffered that was noted. Upon physical examination, the patient's blood pressure was normal for age. However, heart rate was tachycardic, and there was a mild fever as well. Otherwise, the appearance of the patient was fatigued, but well-nourished, alert, and oriented. As noted in cardiovascular findings, heart rate was tachycardic, but rhythm was regular. And there was mild systolic murmur noted upon auscultation, in addition to a pulmonary finding of basal crackles. Neurologically, aside from a slight numbness over the skin in the affected area, the cranial nerves 1 through 12 were grossly intact, and deep tendon reflexes were normal at 2 of 4 bilaterally for both upper and lower extremities. The most notable findings were in the area of head, ears, eyes, nose, and throat. Aside from pale conjunctiva and pupils being equal, round, and reactive to light, which would be normal, The right eardrum was visibly injected and swelling, and as an example, you can see here on the left, this would be what a normal eardrum would look like, and on the right is that of an injected and swelling one. You can see a lot of redness associated as far as color. The patient's intraoral mass in the jaw was approximately 3.5 centimeters in diameter, and there were also dental caries noted on the same side of the jaw and the teeth. Patient's tonsils were enlarged, but no exudates were noted, which would be indicative of inflammatory processes, and there was also no lymphadenopathy noted. Lab tests were ordered, which included a complete blood cell count. This was normal aside from a reduced or low hemoglobin value and a slightly low mean corpuscular volume. Liver function enzyme tests revealed marked elevation in alanine and aspartate aminotransferases, but alkaline phosphatase was normal. For inflammatory markers, we looked at C-reactive protein and erythrocyte sedimentation rates, which were both also highly elevated, in addition to a metabolic panel finding of lactate dehydrogenase elevation, though uric acid values were within normal ranges. So taking these into consideration, we put together our first list of differentials. This focused mainly on the rapid rate at which the progression of the swelling occurred in the mandible. And so the focus was on cancer-associated diagnoses. This began with Langerhans cell histiocytosis, rhabdomyosarcoma, metastatic neuroblastoma, and Ewing sarcoma. So some additional testing to help start ruling these out included a maxillofacial CT with contrast. And as would be represented in our patient, in the right mandible was noted a lytic mass. And by lytic, we mean there's a loss of bone density that's visible when you compare it with the opposite side of the jaw. Our patient's mass was approximately 3.6 by 2.7 by 4.3 centimeters in size, and there were additional lytic areas surrounding the main mass. Biopsy was also ordered, and the initial findings for biopsy were that of small round blue cells. These cells occur in solid sheets with minimal cytoplasm, round or ovoid hyperchromatic nuclei, and the absence of mitotic or necrotic figures, as noted here. Immunohistochemistry was also performed, and our patient's results were positive for S100, vimentin, and CD99, but negative for cytokeratin, desmin, and leukocyte common antigen, which is also known as CD45. So to begin with the differentials, we looked first at Langerhans cell histiocytosis. This disorder has a median age of presentation of about 30 months. It is the most common presentation for Langerhans histiocytosis in the skull of pediatric patients. And the clinical manifestations that led us to first consider this as a differential included the craniofacial lesions and the bone pain both in the mandible and in the leg, as well as the elevated liver enzyme levels. However, upon comparison of morphology in the biopsy, you'll note that as compared to our patient, which has those round and ovoid hyperchromatic nuclei and very little cytoplasm, Langerhans cell histiocytosis instead presents with extensive eosinophilic cytoplasm, and the nuclei are ovoid, irregular, and grooved. So on this basis, we were able to rule out Langerhans cell histiocytosis and move next to rhabdomyosarcoma. Rhabdomyosarcoma is the most common soft tissue sarcoma in patients under the age of 15 and is highly prevalent also in the same areas of the head and neck. Our clinical manifestations that allowed us to choose this one were initially the injected right eardrum and the mild headaches the patient suffered. However, you can see a similar, I guess not really similar, but you can see a difference in the morphology between the patient and the rhabdomyosarcoma here as well, just by morphology alone. And rhabdomyosarcoma cells are spindle-like and also have extensive eosinophilic cytoplasm in comparison to those seen in the patient. You can also sometimes appreciate striations in these spindle-like cells, which is why they're also called myoblasts. Additionally, we had the immunohistochemistry results to further rule this out. negative in our patient for desmin and leukocyte common antigen, but both values would be expected to be positive in rhabdomyosarcoma. So the morphology and immunohistochemistry taken together allowed the final ruling out of rhabdomyosarcoma, leading next to metastatic neuroblastoma. This is a very common lesion in pediatrics. However, it typically presents prior to the age of 5, which in and of itself is an initial indication that it might not be this in our patient, as the girl was 11 years old. However, there are multiple other clinical manifestations that would be supportive of this diagnosis. The bone pain, osteolytic lesions, fever, malaise, and CT and biopsy results would also be expected to be similar. And as you can see, for comparison's sake, looking back at our patient CT, a CT of a neuroblastoma case would reveal similar lesions, that osteolytic loss of mass in the mandible area that's affected. The biopsy would also look nearly identical, with the ovoid hyperchromatic nuclei and the scant cytoplasm in solid sheets. However, the most obvious difference between the two would be the positive CD99 immunohistochemistry result for our patient in comparison to a negative value that would be expected for neuroblastoma. So it was with that result that we were finally able to rule out metastatic neuroblastoma and lead ultimately to a diagnosis of Ewing sarcoma. So to talk about Ewing sarcoma a little bit at first, Ewing sarcoma is a very aggressive bone tumor, especially in the pediatric setting. 80% of the patients that present with Ewing sarcoma are under the age of 20. And we also see commonly fever and the bone swelling and pain in the area of the affected bone, as was seen in our patient. As said previously, the patient had the hyperchromatic round and ovoid nuclei in the histology. And if you note, Ewing sarcoma values would be expected to be about the same. So the morphology would be expected to be identical. And the immunohistochemistry results were conclusive, with positives in S100, Vimentin, and CD99. This allowed us to finally choose Ewing sarcoma as our diagnosis. And I would like to invite student Dr. David Nollick to come and present to you Ewing sarcoma.
Thank you, student Dr. Olson, and I will now continue on with some background on Ewing sarcoma, our treatment plan, some emerging research, ethical considerations, and patient education, and then I'll make some concluding remarks. Ewing sarcoma has recently been grouped with the other primitive neuroectodermal tumors, or PNET, to form a new category called the Ewing sarcoma family tumors. It is also the second most common group of bone cancers in children, second to osteosarcoma. And as we stated earlier, 80% of the cases occur in individuals under the age of 20. It is also highly aggressive and typically responds well to drug therapies. Here is a radiograph of a typical presentation of Ewing sarcoma. They most often occur in the diaphysis of long bones as well as flat bones. The image we see here, we can see some outgrowing here from the proximal end of the femur, a darker mass here, and as well as on the medial side. And it also presents with pain, fever, and a palpable mass in the area. And unfortunately, most patients upon diagnosis will report having pain in the area for up to months beforehand. Here we have some images from a 6-year-old boy who was also diagnosed with Ewing sarcoma of the mandible. Here on the left we can see just a straight photograph. You can see the mass growing here, and you can even see his teeth being pushed out of the way there. And on the right we have a radiograph showing the typical moth-eaten appearance of Ewing sarcoma, pushing the teeth out of the way. Ewing sarcoma comprises of 1 to 9% of all tumors in the head and neck region, with less than 3% of all ES cases occurring in the mandible or having mandibular involvement. And the 5-year survival rate of individuals with a localized tumor is 70%, and that decreases to 20 to 25% when the cancer has metastasized. And both of those figures account for aggressive chemotherapy, radiation, and surgery treatment. Some demographics, again, we said 80% occur under the age of 20. However, most of that is in the second decade of life. The chart shown here shows the incidences of Ewing sarcoma in the year 2004. It is markedly more common in males and up to 9 times more common in Caucasians. It is extremely rare to see Ewing sarcoma in African Americans or individuals with Asian heritage. The 2 genes that are responsible for Ewing sarcoma are the FLI1 gene and the EWSR1 gene. The FLI1 gene is located on chromosome 11. It is a proto-oncogene, and its function is to bind to DNA and act as a transcriptional regulator and to promote the cell cycle. And EWSR1, there is not much known about it other than it's located on chromosome 22, and it acts as a ribosome RNA binding protein. And the only other information known about it is that it is involved in Ewing sarcoma. The genetic mechanism involves a translocation between chromosomes 22 and chromosome 11. Shown in the graph table here on the side, we can see our normal chromosomes. 11 is a darker gray color and 22 is a lighter gray color. And upon translocation, we have a derivative hybrid chromosome. And the genes aren't translocated separately, they're translocated on top of one another. So instead of having 2 separate proteins transcribed, we have 1 hybrid protein that is transcribed with active sites from both proteins. And so Ewing sarcoma is caused by this hybrid protein that has the DNA binding region of FLI1 and the RNA activating portion of EWSR1. And this leads to uncontrolled regulation and dysregulation of the cell cycle, which leads to abnormal growth. And this particular translocation involving FLI1 is involved in 90% of Ewing sarcoma cases. And the image we see here on the bottom, we can see our normal chromosome is stained red and green here. Here's 11, here's 22, and here's what we would expect in that translocation. You can see portions of both chromosomes present. Okay. So before we make a treatment plan, we first have to stage our patient's cancer. In doing so, we use an Ewing staging system, which has 3 components: a grading scale, which levels the differentiation of the cells, basically what the cell looks like compared to what we would normally expect in the area, the anatomical extent or the size of the growth of our patient, as well as signs of metastasis. And so using CTs and other bone scans with concerns of the lung crackles and the pain in the tibia, we had to rule out metastasis. So our scans showed no metastasis. The tumor was in the smaller region, and the cells were also well differentiated, which gave us a stage 1 Ewing sarcoma. Our treatment plan involves a multi-agent chemotherapy, which is a 6 3-week cycle as per the Ewing 99 protocol. The treatment is a neoadjuvant treatment, which means that we want to use chemotherapy to get the tumor to a more manageable size in order to excise it via surgery. And another issue to take in consideration is that the growth is on the mandible, and more than likely that mandible would need to be resected or partly resected. And after that surgery of resection, immediately facial reconstructive surgery would have to take place as well. And so our treatment plan involves these 4 drugs. Vincristine is an antimicrotubule agent which prevents the spindle apparatus from forming during cell division, and without the spindle apparatus, the cell can't divide and eventually will die. Ifosfamide is a DNA alkylating agent, which means that it will bind to the DNA bases and prevent appropriate base binding, and this leads to DNA strand breakage, which also causes cell death. And doxorubicin and etoposide both act on topoisomerase, which prevents DNA synthesis. And once they bind to topoisomerase, they lock it onto the DNA strand and also causes a double-stranded break, which leads to cell death. And collectively, all these drugs work and function to keep dividing cells from dividing and also kill cells that are trying to divide. And an unfortunate side effect of this is immunosuppression, myelosuppression, so your body can't produce those white blood cells to fight off infections. Osteopathic manipulative medicine was contraindicated by a malignant cancer, so using OMM has a likelihood of causing metastasis of your cancer. And our patient outcome, unfortunately, after the first round of chemotherapy, the patient developed fever, neutropenia, and sepsis, and the patient did not respond well to antimicrobial therapies, which ultimately led to her death after a few days of treatment. Some emerging research in the field of Ewing sarcoma and other cancers involve alternative treatments, and this drug or treatment plan, Vigil, uses the patient's own cancer cells to create a vaccine against their own specific cancer. And firstly, that involves removing a portion of the tumor and modifying the cells to be injected back into the patient. And the first modification that is used in this drug is the granulocyte macrophage colony stimulating factor is activated in order to activate or promote dendritic cells on sampling those tumor cells. And then the second modification is inhibition of TGF-beta 1 and 2 secretion. And what TGF-beta 1 and 2 does in a normal cancer cell is it masks the cancer cells from being recognized by dendritic cells. And so we can see here we are inhibiting that secretion here and increasing the GM-CSF. And so that promotes dendritic cells to take up our injected cancer cells to then activate cytotoxic T lymphocytes to then seek out the tumor cells and destroy them. And currently, Vigil is in the second phase of clinical trials, and it shows promise for treatments other than chemotherapy that have the side effect of destroying the immune system. Some ethical considerations when treating pediatric cancer patients. First, we want to talk about truth-telling in pediatric patients, and this is where parents or other individuals will try to keep the full extent of the disease or the treatment from the patient, which infringes on their autonomy in making a decision on their own. As well as deciding on treatment levels, especially in the case of our patient where the mass was located on the mandible, there were multiple factors to consider in the types of treatment we wanted to go with. And so there's considerations on how aggressive we are with treatment, followed by surgeries that are also an option. And another ethical consideration would be palliative and hospice care for cancer patients, depending on how they respond to the treatment and how the cancer progresses. And for patient education, it is important to give them information on their disease specifically, as well as provide them with support groups and counseling. One organization in particular is the Sarcoma Foundation of America, and it provides funding for research into sarcomas, including Ewing sarcoma, as well as support information and support groups. We'll conclude with that Ewing sarcoma is a rare and serious diagnosis for pediatric patient facial swelling. As I stated earlier, it occurs in less than 3% of all Ewing sarcoma cases. And as of right now, the standard of care was the chemotherapy treatment, and it was met with an unfortunate outcome that our patient died from infection as opposed to the cancer. So this kind of leads us to believe that she was killed by the treatment instead of the disease itself, which leads us to promising emerging research where the immune system is actually promoted as opposed to destroyed. Our sources, and we would like to acknowledge Ms. Loring Fitterling, Dr. Hirsch, Dr. Dobson, and Dr. Boehm, and then we'll continue with questions.
So if you guys want to go ahead and put in your questions either into IM or bring your cards down so that Group 5 can answer those questions for you. We also have Dr. Hubbard here, who's also a hem-onc specialist. So we're very grateful to have him here as well.
Hi, my name is student Dr. Ben Merbler. We got a question asking why Ewing sarcoma is typically more responsive to chemotherapy than other cancers is. And the answer to that is because in most cases, as we mentioned, well, maybe not most, but majority of cases, 75%, as David mentioned, this cancer has not metastasized to other locations in the body. So particularly the lymph nodes aren't affected. And because of that, this is usually a more responsive type of cancer to those chemotherapeutic drugs. A big player in that is the CD99 that Rachel mentioned earlier during our differential diagnosis. The CD99 actually acts to modulate the migration of those cancerous cells to different locations, and then also makes the body more responsive to those chemotherapeutic drugs.
Hello, I'm student Dr. Jacob Moore. The question I got is, what is CD99? As we learned in immunology, it is a cell surface protein. It's a glycoprotein. It's highly expressed in most cases of Ewing sarcoma family tumors. It's encoded as a pseudo-autosomal gene in both X and Y chromosomes. It normally has a function in cell adhesion, migration, apoptosis, differentiation of T thymocytes, migration of lymphocytes to inflamed vascular endothelium, maintenance of cellular morphology, and the regulation of intracellular membrane protein trafficking. But in cancer, in Ewing sarcoma in particular, the modulation of CD9 expression, it significantly modifies cell growth in anchorage-independent conditions, and the CD99 contributes to the tumor cells' proliferation, migration, and metastasis.
Hi, my name is Monica. My name is student Dr. Monica Paravastu, and my question is, what is intussusception? So intussusception is when part of the intestine slides into the adjacent part of the intestine, and this blocks any fluid and food from passing through. This also cuts off any blood supply to part of the intestine that is affected, and this can lead to tissue death. This condition can be corrected through surgery.
Hi, I'm student Dr. Bhavna, and one of our questions is, what are some other small round blue cell tumors in kids? So small round blue cell tumors are classified based off their distinct histological appearance. So these include neuroblastoma, rhabdomyosarcoma, which are ones we've discussed in our differentials, and also non-Hodgkin's lymphoma, retinoblastoma, hepatoblastoma, and Wilms tumor. So considering that these tumors have a similar histological appearance, it's important that the initial accurate diagnosis is made so that treatment options, responses to therapy, and prognoses vary widely depending on the diagnosis.
Hello, I'm student Dr. David Nollick again, and the question I have is, do you use a neocassette in the Vigil proposal, or how would you insert it? And currently, in its current trial, Vigil is administered intradermally in the upper arm, 1 dose per month for up to 12 months as needed.
Good morning, guys. I'm student Dr. Natasha Matthew. The question that I received are, what are dental caries? As noted in our patient case, along with her intraoral mass that she possessed, she also possessed dental caries, I believe, in the right mandible. Simply put, dental caries are cavities, but the mechanism of action, so every day the food that we eat, the normal flora, the bacteria within our mouth, breaks down the food into acids, namely the sugar and starch that we eat, and the buildup of these acids can combined with the food particles and the bacteria can actually form plaque. If the plaque isn't removed after a period of time, it can build up, and then the acids within the plaque can actually damage the tooth enamel And with the damage of the tooth enamel is what forms those holes in your teeth, which can cause the painful cavities. Depending on the severity of the cavities, of course, you'll have to visit the dentist. More severe forms of cavities will require some extensive treatment or even possibly removal of the tooth.
Good morning. I'm student Dr. Jaron Nielsen. I have a question regarding one of our tests that we ran early on. It is, how do you measure corpuscular volume? We measure that by multiplying the volume of the blood sample by the proportion of the blood that's cellular, which is our hematocrit. And then you divide that number by the number of erythrocytes in that volume. Sounds a little complicated, but in practice, this is measured by an automated blood cell counter. And what this number really does for us is it allows us to provide a way of distinguishing between microcytic, normocytic, and macrocytic anemias.
Hello, I'm student Dr. Von Nguyen, and the question was, what's the difference between osteolytic versus osteoblastic? And they're both bone metastases that are either or. The osteolytic metastases are usually a type of progressive cancer that causes thinning or breaking down of bone tissue. And this usually results in the calcium being released from the bone and into the bloodstream. And on the other hand, osteoblastic lesions result in excessive signaling of osteoblasts and deposits onto the bone matrix, which overproduces bone cells and results in rigid, thickened, and inflexible bone being formed.
Good morning. I'm a student Dr. Jordan Maxwell, and we received the question that despite the absence of a family history in this patient's case, does Ewing sarcoma typically have a genetic component? And yes, in that patients with Ewing sarcoma often have the translocation between chromosomes 11 and 22, as we showed. But this translocation is not inherited from parents. It is acquired during a person's life. And that translocation is only found in the tumor cells. So as long as you remove the whole tumor, then you don't have any translocations left in the body of the 11 and 22 that would cause Ewing sarcoma. So it would not be passed on to your children.
So we had one more question. It's who ultimately makes treatment decisions for pediatric patients? Ideally, you would want the physician and the healthcare team collaborating with the patient as well as the parents. In most cases, though, it ends up being one of the parents who does make the decision. However, if the child or young adult, if they're 12, 13, if they are deemed capable to make their own decisions and are competent, then what they want to do or what they have to say is more heavily weighted. Thank you.
So thank you, Group 5. I mean, that was a very complicated and difficult case, which resulted, unfortunately, in the death of this child. And so just remember, as osteopathic physicians and care providers in general, you know, some of you may either have experienced or have family members or relatives that have been diagnosed with cancer, and that can be very overwhelming, not only for the patient, but for the entire family and everyone involved. And it was nice that you guys brought up the Sarcoma Foundation. And so it's always good to give patients educational materials, because if you meet with a physician in 30 minutes, they may give 5-year survival rate, treatment plans, and patients may not be able to either understand or take all that information in. And it's nice to be able to give them resources where they can go home and either read up on it, get the support that they need, and make an informative decision. That way you have a patient that's engaged in their own health care. So either the Sarcoma Foundation or the American Cancer Society, and I tend to use the American Cancer Society for a lot of my patients, and the reason being is the American Cancer Society has resources in both Spanish as well as Asian and Pacific languages, because you're going to come into contact with patients that English may not be their first language, and they may not understand what it is that you're saying. So providing resources that they're able to understand and ask questions questions is very valuable to them, and they will appreciate you as a physician by giving them that information so that they can be more informed to make a decision about how they want to proceed with their care. Are there any other comments? Okay, why don't we take a few minutes? Please give Group 5 a round of applause for this wonderful presentation.
Okay, I need to be behind here because I'm wearing a dress, so.
Sure, that's fine.
Whose laptop is this?
I think that's Zach's.
Tyler, we're sitting next to each other again? Yep, we're gonna cuddle up on that.
Yeah, sure.
You can watch me seriously tight. Here, I'm gonna squeeze real tight. Yeah. Are you guys gonna be able to fit on that side?
I mean, we have, I think, our groups
On. Because we barely got John in here.
Weirdly close to you.
I love the Excel spreadsheet chatter.
Is this mic on? Yep.
Do you want to just pass the mic on the actual stand?
Okay, the LDH question. Is that okay? The LDH question that no one has answered.
We don't have to.
Oh,
I think we're
James
gonna
is gonna
answer
answer
this
this.
oh.
one.
Press the button.
That's on.
Okay, class of 2020, we're going to go ahead and get started with Group 6, and their grand rounds will be on mysterious bruising, weakness, back pain, and gum bleeds. Again, a very complicated case, so please give them your full attention. Send in your questions on IM chat, or go ahead and fill out the card so that they can go ahead and, again, they can't answer all the questions that are sent in, but they will try to get to the majority of them. So please give them your full attention.
Welcome to our Grand Rounds presentation. We're Group 6, and we'll be presenting the Medscape case of mysterious bruising, weakness, back pain, and gum bleeds. These are the team members of Group 6. I'm student Dr. Gabby Rico, and I'll be presenting the patient case overview. Our patient is a 42-year-old female who presented to the emergency department with a chief complaint of bleeding from the gums for the past 2 days. She also had associated symptoms of progressive weakness, occasional bruising over the buttocks, thighs, and shoulders for the past month that had been occurring without significant trauma. She denies hematemesis, which is vomiting of blood, and melena, which is a dark or tarry stool sample that can indicate a GI bleed. She also denies hemoptysis, which is coughing up blood, and epistaxis, which is nosebleeds, and she's negative for fever and rash. The patient also reports having low back pain for the past year, for which she's been using oral analgesics. The patient has no past medical history, and her surgical history is unknown at this time. She has no known drug allergies, and she's not taking any regular medications with the exception of intermittent use of oral analgesics. The patient's family history is unknown, and she drinks 1 to 2 cans of beer daily, does not use tobacco or illicit drugs. She's unmarried, lives alone, and is employed as an office clerk. These are our patient's vital signs, and as you can see, her temperature, heart rate, blood pressure, respiratory rate, and oxygen saturation on room air are all within normal range. Upon physical exam, the patient is alert and in no apparent distress. She also appears her stated age. The patient has pale sclera bilaterally, but no evidence of scleral icterus. The patient has normal heart sounds, and her lungs are clear to auscultation. The patient's abdomen is soft and non-tender, and there's no palpable organomegaly. The patient also has ecchymotic patches that range from 2 to 4 centimeters in diameter on the buttocks, thighs, and shoulders, as well as small petechial spots that are noted on the scapular and abdominal regions. And this image here depicts nicely the difference between ecchymotic patches here and the smaller petechial spots. They're both bleeding within the skin, but the difference is in their size. The patient has no evidence of cervical, axillary, or inguinal lymphadenopathy. And upon rectal exam, the patient has normal sphincter tone and no evidence of blood. We ran a complete blood count for our patient, and we found that she was severely anemic, and she also had thrombocytopenia, as evidenced by her low platelet count. We also ran a comprehensive metabolic panel and found that the patient had elevated lactate dehydrogenase and elevated alkaline phosphatase. Our patient's erythrocyte sedimentation rate was elevated. However, her iron tests were all within normal range. Our patient's coagulation profile was within normal range, as well as her haploglobin test, and she also had a negative direct antiglobulin test. We ran a peripheral smear for our patient, and what we found were many banded neutrophils, occasional metamyelocytes, nucleated red blood cells, and a few plasmacytic lymphocytes. When we see these immature cells in circulation, it can be a sign that there's a functional issue in the patient's bone marrow. We also ordered a skull radiograph for the patient, and what we saw were these multiple punched out osteolytic lesions, as you can see here. And we also saw these lesions in the lumbar spine, pelvic bones, and scapula, and so here are the lesions on the lumbar spine x-ray. This figure summarizes our patient's symptomatic presentation and ties it to our 4 differential diagnoses. So our patient presented with progressive weakness, fatigue, and bruising without significant trauma, bleeding from the gums. These symptoms tie into 2 of our differentials, which are acute myeloid leukemia and multiple myeloma. Our patient also has been experiencing low back pain for the past year, and that ties into our other 2 differentials, which are metastatic carcinoma and Paget's disease. First, we'll discuss acute myeloid leukemia. This is a cancer of the myeloid line of blood cells, and it's characterized by rapid growth or an excess of abnormal or immature white blood cells. Patients commonly present with history or chronic progressive lethargy. They can be acutely ill and have skin, soft tissue, or respiratory infections. Patients can present with petechiae with or without bleeding, and the median age of presentation is 65. Next, we'll discuss metastatic carcinoma. Carcinoma is a cancer of epithelial cells, and metastatic carcinoma is when that cancer breaks away from its site of origin and spreads to a different part of the body. This can present differently depending on where the cancer is spread. So if it spreads to the bones, patients can have pain or fractures. If it spreads to the brain, patients can have headache, seizure, or dizziness. If it spreads to the lungs, patients can have shortness of breath. And if it spreads to the liver, patients can present with jaundice or swelling in the abdomen. Multiple myeloma is characterized by malignant proliferation of the plasma cells in the bone marrow, and patients commonly present with spine pain, pathological fractures, symptoms related to anemia. They can have bleeding and even peripheral neuropathy. Lastly, we'll discuss Paget's disease. This is a disruption in the normal bone remodeling, and what happens is there's a unorganized or chaotic deposition of new bone, which leads to the bones being fragile and misshapen over time. This commonly occurs in the pelvis, skull, spine, and legs, and patients can be asymptomatic, but often they'll have bone pain. This chart summarizes our patients' lab findings and x-ray findings and allows us to compare them to our 4 different differential diagnoses. So if we start by comparing to acute myeloid leukemia, we can see that our patient's white blood cell count and erythrocyte sedimentation rate is not consistent with what we would see in acute myeloid leukemia, so it's less likely that that's our patient's diagnosis. If we compare to metastatic carcinoma, we can see that our laboratory findings of serum iron and their renal function are not consistent with what we would see in metastatic carcinoma, so that's also less likely to be our patient's diagnosis. We can compare to Paget's disease, and not only are our laboratory findings not consistent, but our x-ray findings of the osteolytic lesions are not consistent with what we would see with Paget's disease, where you would see deformed or large bones. So it's also less likely that Paget's disease is our patient's diagnosis. At this point, all of our laboratory findings and x-ray findings are consistent with what you would see in multiple myeloma. However, there are a few more tests we need to run to confirm this diagnosis. We ordered a 24-hour urine analysis for our patient, and this came back negative for protein. This is significant because in multiple myeloma, you would expect to see protein in the patient's urine. We also ran a beta-2 microglobulin test, and this came back elevated. This test is significant because it's a tumor burden marker. It can give us an idea about our patient's prognosis. We also ran a serum protein electrophoresis, where we saw no M protein or myeloma protein spike. And this is significant because this is something that you would see, an M spike is something you would see in a patient with multiple myeloma. Lastly, we did a bone marrow biopsy, and what we saw were sheets of plasmacytic cells in various stages of development. And we also saw a marked replacement of normal hematopoietic tissue. Over 90% were morphologically plasmablasts, and the biopsy was also positive for antibodies to CD38, CD138, CD56, and lambda light chains. So these results are very characteristic of what we would see in multiple myeloma. So tying in the results of this biopsy with the fact that we did not see an M spike on the serum protein electrophoresis and that we did not see protein in the patient's urine brings us to our final diagnosis, which is non-secretory multiple myeloma, and this is a rare variant of multiple myeloma. So now I'm going to turn the presentation over to student Dr. John Peterson so he can discuss that with you further.
Thank you, student Dr. Rico. My name is student Dr. Peterson, and it will be my pleasure to present on the disease pathology, treatment, ethical considerations, and patient education in our case. In order to understand non-secretory type multiple myeloma, we first have to understand multiple myeloma. Put simply, it's an uncontrolled proliferation of clonal plasma cells in the bone marrow. So as you can see in this diagram, we have all these abnormal plasma cells growing out of control in comparison to what you would have in normal bone marrow, these normal plasma cells. A helpful mnemonic for understanding some of these symptoms of multiple myeloma is that of CRAB. It stands for hypercalcemia, renal failure, anemia, and bone lesions. Our patient had 2 of these very common symptoms. Multiple myeloma is the 14th most common type of cancer in the United States. It represents 1.8% of all new cancer cases in the US. And it is the third most frequent blood malignancy, right behind non-Hodgkin's lymphoma and leukemia. The median age at diagnosis is 69 years old. So multiple myeloma has different stages in it. One such stage is this here. It's called monoclonal gammopathy of undetermined significance. So this happens in 50% of patients because of a translocation at chromosome 14, and the other 50% of patients due to a deletion of chromosome 13. This stage is important because it is asymptomatic. It is pre-malignant. There's no end organ damage here. The only way that you can track this stage is through the M proteins that are being secreted. So it's important because you can track the progression of the disease here. It then takes a second hit to become the malignant stage, the end organ damage stage of myeloma, and that can occur due to a RAS mutation, a P16 methylation, P53 methylation, or even a secondary translocation. So as student Dr. Rico said earlier, our patient was confirmed to have multiple myeloma via the bone marrow biopsy. And on this serum protein electrophoresis, you can see a very prominent M spike, and that would be very typical in a multiple myeloma patient. This is a normal, quote-unquote normal serum protein electrophoresis. However, what's interesting here is this is what our patient presented with, and this is also the common serum protein electrophoresis for those with non-secretory type multiple myeloma. So in 1 to 5% of all multiple myeloma cases, that M protein is not detected in the serum. It's important to note, though, that even though that M protein is not detected there, the trademark symptoms and treatment are the same for non-secretory type multiple myeloma and multiple myeloma. So one of the hallmarks of multiple myeloma is that of these osteolytic lesions. So as you can see here, here's a very big one. We've got multiple all over the skull. And these are thought to occur because of an imbalance between osteoblast and osteoclast activity. As those osteolytic lesions start to coalesce, you get weakening or osteopenia of the bones, and it can even lead to fracturing of the bones. Another common symptom of multiple myeloma is fatigue, and this is secondary to anemia. So with a higher number of plasma cells in the serum, you have less room for red blood cells, and that leads to a lower oxygen carrying capacity, and we fatigue quicker. A final common sign or symptom of many diseases, but specific to multiple myeloma, is that of rouleau formation. So as you can see here in this bottom right image, we have normal red blood cells. And in the top right, we have this chain-like stacking of red blood cells, which is characteristic of the rouleau formation. This occurs due to an increase in serum proteins, and this causes an increase in the erythrocyte sedimentation rate, which our patient did have. Prognosis is based on many factors. It can be based on an increase in beta-2 microglobulin levels, LDH levels, epigenetics, genomic instabilities. The more factors you have, the worse the prognosis becomes. We look specifically at the International Staging System, which measures the beta-2 microglobulin levels. Our patient was classified based on this staging system as stage 1, with a median overall survival of 62 months without any treatment. So the ultimate goal of treatment is to control proliferation and manage pain for our patients. And with treatment for patients such as ours, the median survival is 6 to 8 years. In this case, OMM is an absolute contraindication. We do not want to do myofascial release or lymphatic treatment, for example, because we do not want to have hematogenous spread. Patients are split up into 2 different categories for multiple myeloma, those that qualify for autologous stem cell transplant and those that do not. Our patient did qualify because of her age and her likelihood of accepting the stem cell transplantation. And so we will run through the different stages of this treatment. First of all, we have induction therapy. So you have a 2 to 3 drug regimen And this is used to destroy all the cancerous cells and prepare for a stem cell harvest. After doing this, you go into consolidation therapy, and that is when the actual stem cell transplantation occurs. You have chemotherapeutic drugs that then destroy any further cancerous cells. And then we go into maintenance therapy and hope that the patient does not relapse. So our patient received an induction therapy of thalidomide, which is an immunomodulatory drug. She received cyclophosphamide, which is a chemotherapeutic alkylating drug, and dexamethasone, which is a corticosteroid. She's currently stable and awaiting stem cell transplantation. There's been great success with this type of treatment that I just explained. However, multiple myeloma is still a disease of relapse and refractoriness. And so there's much research being done to try to improve the outcomes. One drug that has had great success is pomalidomide, which is an immunomodulatory drug that is used to increase the levels of natural killer cells, IL-2 and interferon gamma. Carfilzomib and ixazomib are proteasome inhibitors that are used to target cellular complexes that are breaking down proteins. These three drugs have had great success as second-line treatments in patients that have relapsed. And because of their great success, they will be used in the upcoming years as frontline treatments. Finally, we have monoclonal antibodies, and these are really becoming the center of research in not only multiple myeloma, but many diseases because they can be so specific. One such drug that is FDA approved right now is daratumumab, and this drug is very specific to multiple myeloma because it targets that CD38 cell that student Dr. Rico was talking about. As far as ethical considerations go, one of the largest is that of risk versus benefit of treatment. From an article, we found this statement that says, "Fatigue can lead patients to abandon treatment and can be so overwhelming that some patients say they would rather die." It's important that we make our patient aware of what life will be like with and without treatment so that she can make an informed decision. Another thing to consider is that our patient lives alone, so we need to know that she has a plan in case something goes wrong in the treatment. Furthering with ethical considerations, we have patient education. These are the three drugs that our patient was put on for induction therapy, and they have some severe side effects. So thalidomide can cause phocomelia in the fetus, and that is when the hands and feet grow directly from the torso. There is no arms or legs. This can happen up to 4 weeks after taking the drug. Cyclophosphamide can cause ectrodactyly, which is that of split hands, so you don't have those middle digits or split feet. And this can happen up to a year after taking this drug. And dexamethasone should not be taken with alcohol. Furthering our patient education, there are multiple foundations for multiple myeloma, and this is really a great resource for our patient. Being that she lives alone, she will need to have people that she can relate to and that she can learn different things about different treatments, different clinical trials, and how to cope with this disease. Our take-home messages are threefold. One is that disease pathologies have many variations. So when we're looking at coming up with our final diagnosis, we should not rule out a diagnosis because of one variation. We should do some further testing. Our second message is that of familiarity with common characteristics of diseases is key. So the mnemonic of CRAB for multiple myeloma helped us to have a differential diagnosis right away when our patient came in. And finally, we have interdisciplinary cooperation. In order to diagnose and treat this patient, it took a lot of work from a lot of people from a lot of different fields, a lot of different specialties and professions. So as future physicians, we need to learn to work well with people from all different specialties and professions so that we can provide the best health care for our patients. We would like to thank these people specifically for helping us polish our presentation. These are our sources. Are there any questions?
Hi, I'm student Dr. Dominic Royster. We had a question regarding autologous stem cells, how they're actually harvested.
According to update, we have hemopoietic cells are generally collected before the patient is actually exposed to any alkylating agents. These are generally harvested directly through the bone marrow or actually through a technique called apheresis, essentially taking away those actual cells they need from the blood. This is considered a peripheral blood harvest. Essentially, you do this by stimulating the blood using GCSF, and that's granulocyte colony stimulation factor. This is done over the course of 4 to 6 days. This process can typically take 4 to 6 hours. It obviously depends on donor size, how many progenitor cells we're trying to get, and stem cell count. The process generally, what they're trying to do is get a goal collection of 3 to the 10 to the 6 of the CD34 cells, and this is cells per kilogram. After which the progenitor cells are then essentially, excuse me. After the progenitor cells are actually harvested from the bud, they then usually try to give a dose that's at least at a minimum of 2 to the 10 to the 6 CD34. And then after which, essentially after the transplant's been done, we try to look at the patient and see whether or not we actually need to do continual treatments. This is considered tandem treatments. And the other cells that were actually harvested then go into cryopreservation. So then they were later on assessed and see whether or not we need to use those for future treatments.
Hello, I'm student Dr. Zach Rosrenault. We received a question, are patients with multiple myeloma more susceptible to infections? Infections actually are a significant cause of morbidity, leading to death in patients with multiple myeloma. The reason is due partly due to reduction of normal immunoglobulin production, which leads to defects in the complement cascade and other immunologic mechanisms. A lot of that has to do with the cancer treatments going on. And we actually found a study that shows that within the first 2 months of treatment, patients are 4 times more likely to get an infection than those not receiving the treatment. So it's really important at the beginning to pay attention and monitor them for those infections.
Hi, I'm student Dr. Sam Puella. We got a couple questions about hypercalcemia in multiple myeloma patients. So in these multiple myeloma patients, the primary cause of hypercalcemia is widespread tumor-induced bone destruction. This is primarily due to increased osteoclastic bone resorption, which is caused by potent cytokines expressed or secreted locally by the myeloma cells, or they can also be overexpressed by other cells in the local microenvironment. And this bone resorption in turn leads to efflux of calcium into the extracellular fluid. However, the pathogenesis of hypercalcemia in myeloma is probably more complex than this because not all patients with significant myeloma bone disease develop hypercalcemia. And even in patients who do develop it, sometimes this isn't developing until much later in the disease. If you notice in our case, they didn't even run a hypercalcemia test. So.
Hi, my name is student Dr. Kyle Scharf. We received the question, why was our patient deemed to have non-secretory multiple myeloma despite testing positive for lambda light chain antibodies, and what is the significance of that? So calling it non-secretory can be a bit misleading. In about 85% of cases of non-secretory, the cells are still producing antibodies, but they're not detected by conventional urine or serum techniques like SPEP for monitoring these immunoglobulins. This is significant because light chain multiple myeloma is, renal failure is a much greater part of the disease. But our patient, despite having this antibody, wasn't actually assayed for her level of lambda light chain antibodies, so that is something we could consider doing.
Hi, I'm student Dr. Emily Sauk, and there were multiple questions around urine test and specifically Benz-Jones proteins, and what are they? So Benz-Jones proteins are a light chain portion of the monoclonal globulin protein, and they are a diagnostic protein of multiple myeloma, especially in context with end or end organ manifestations. So you're seeing this in a lot of renal failure functions. So this is present in about 2/3 of the cases, and our patient, while did have a urine test, did not have the M spike and did not have Bence-Jones in her urine.
Hey y'all, my name's student Dr. James Panati. I got the question, did normal levels of haptoglobin have any influence on the determination of your diagnosis for our patient? And yes, it did. So in this case, the normal level actually was significant. So haptoglobin is a protein that's secreted by your liver. It binds to hemoglobin, and whenever your body is constantly, replacing its red blood cells, you need to break down the hemoglobin that's released into your blood. Typically in patients or people, with anemias, the red blood cells are lysing, releasing the hemoglobin into the blood. Haptoglobin will bind. Therefore, with patients with anemia, you'll see a lower level of haptoglobin when you run a test for it. In our patient, it was normal. And that was because she has cancer in her bone marrow. So this is a producing red blood cell problem, not a lysing red blood cell problem in the periphery.
Hi, my name is student Dr. Jameson Reich. We received a question on what is beta-2 microglobulin and what makes it. So beta-2 microglobulin comes from a gene on chromosome 15 and is part of the major histocompatibility complex class 1 molecules, which are present on every nucleated cell in the body. And they work to present non-self antigens to cytotoxic T lymphocytes. So just to clarify why this is used as a prognosis factor in multiple myeloma, multiple myeloma are malignant plasma cells, and so because the plasma cells are proliferating uncontrolled, there are more cells in the body, which means there's more beta-2 microglobulin. So the higher level of beta-2 microglobulin is the higher proliferation of these malignant cells, and the worse the prognosis is.
Hi, my name is student Dr. Priscilla Guok, and we got a question, why doesn't our patient have an M spike? So the M spike is referring to a spike in monoclonal immunoglobulins, which is normally detected in multiple myeloma patients due to the proliferation of a single clone of plasma cells, which secrete the clonal immunoglobulins. So in non-secretory multiple myeloma, there's no M spike because either the tumor cells are not actually producing the monoclonal immunoglobulins, or they're quickly degraded in circulation. And so there is data that suggests the reason why they might be quickly degraded may be due to there's some kind of abnormality in the structure and which causes their quick degradation.
Okay, so group 6, you did a wonderful job on a very complicated case. And so just remember that, again, as osteopathic physicians, that we have to treat the whole body. And so as a primary care physician, we need to make sure that our patient is ready to undergo treatments, because once they start treatment, it does suppress their immune system, and they're able to pick up things that maybe they would be able to fight off if they weren't undergoing treatment. So right now, what's one of the vaccines that maybe we should all be getting that we need to let our patients know about? The flu vaccine, right? So when you are taking care of these patients, especially if you're going to be a primary care physician, you need to make sure that their influenza vaccine, their pneumococcal vaccine, which there's 2 now, there's the 13 and the 23 valent. If they're going to travel, are they up to date on their hepatitis vaccines? So just make sure that these patients, they're going to be going through therapy, and they're put at risk for things that maybe they would be able to fight off if they weren't. The other thing is, this is a multidisciplinary approach when you're taking care of these patients. When they go through therapy, they may need nutritional support, because a lot of these medications can cause nausea, vomiting, and decreased appetite or anorexia. So just be aware that when you are taking care of these patients, it is a multidisciplinary approach. Make sure you're taking care of the whole patient. So thank you, Group 6. I mean, this was a very complicated case, very well presented. Do we have any comments from the group, from the class? Student, or Dr. Hubbard. Student Dr. Hubbard. Yes, sir.
Thank you, Dr. Coffin. Yeah, you will be students the rest of your life, so I don't object to the title student doctor at all. Both student doctors, both groups, fantastic job, you guys. Welcome to the world of oncology. It's a challenge, isn't it? These are hard cases, aren't they? I mean, they're really, really a challenge, but that's the nature of oncology. If you look at statistics, probably everyone in this room, if you look at your extended family and your friends, have probably been touched by cancer already. And the part that I really hate about this, particularly because, you know, in my age group, we tend to be just a little paternalistic of the people we're training. The reality is by the time we're all said and done, 1/3 of you are going to have a personal experience with a malignancy. And so this is something that hits very, very close to home. Now, the take-home message with these two cases is even though it doesn't feel really good in the room, over 2/3 of patients who get diagnosed with cancer survive their disease. So we're winning the war. And the people in this room, all of you, are going to be responsible personally and professionally for making sure that that number reaches 100%. We're not stopping at 80 or 90 or 95. We're going for a perfect score. Nothing else will be acceptable. But it's going to take all of us together to make that happen. You've heard in part of my last comment, you've seen some things with both of these cases. You've seen genetic abnormalities. You've seen things expressed aberrantly, and you've heard about treatments that take advantage of those things. So when you're studying your basic science stuff, it's not just for boards. It's not just foundational. You will take this to work with you the rest of your life. So think about those genetics, think about the biochemistry, think about the physiology, think about the anatomy, the immunology that goes with that, the pharmacology that goes with that. Be complete physicians because you're going to need that to help your patients be successful. We're developing targets for each and every one of these things, and it gets better all the time. So keep up the good work, study hard, let's all work together, and let's win this thing once and for all. We've got a country that really needs us at our best. That's it.
So, but before the class of 2020 steps out, I was asked if you guys could stay back just for a few minutes because there's going to be a group survey. So if you guys don't mind holding back just for a few minutes for that group survey. Thank you. And thank you, group 5 and 6, for a wonderful presentation.